Now let me share some further details about this trial. And specifically, I'm going to use our curriculum wheel to discuss some of the nuts and bolts around different sections or aspects of the trial. In terms of our intent and question, as you heard, we wanted to know if adopting a default center-wide policy of personalized cooler dialysate was superior to standard temperature dialysate for improving health outcomes. Our primary intent was to inform the decision of what default center-wide policy a dialysis director should use in their centers, where nephrologists and patients continue to have the option to individualize care. In thinking about the question and intent, of course, you're also trying to fill an evidence gap. And as described earlier, there were core studies that suggested a lower dialysate temperature was associated with better survival and less cardiovascular disease. And there are 26 small randomized controlled trials totaling less than 500 patients that suggested a fixed reduction in dialysate temperature reduced the rate of intradialytic hypotension. However, the conclusion was uncertain. And really what we were hoping with this trial is that we were going to show that cooler temperature dialysate improved outcomes that matter a great deal to patients and their providers. And by doing so, we would encourage adoption of this technique worldwide, which is fairly easy to scale and implement. And that would result in substantially less heart attacks and strokes and cardiovascular mortality each year, preventing several thousand events each year. But the trial did not show that. And it's interesting that we do this many times in medicine where we base our practice based on limited evidence and it gets adopted. And that really highlights the importance of high quality evidence informing good policy and good practice. Also, this often occurs in practice where guidelines get written around evidence that is perhaps less strong than it can be. And for example, there was a 2007 European guideline that suggested lower temperature dialysate should be used in patients with intradialytic hypertension with level 1 evidence. In terms of the trial design, this was a pragmatic 2-arm parallel group registry-based open label cluster randomized superiority trial, certainly a mouthful. And for those who are interested, the protocol was published. We also use covariate constrained randomization. When you randomly allocate 84 centers into 2 groups, by chance alone, you could get meaningful imbalance on important baseline characteristics, and then that causes some consternation amongst readers of the trial because they're concerned when they see differences in outcomes, whether that's due to the baseline imbalance rather than intervention effects. And even if you adjust for those baseline imbalances, there still remains some concerns. So we used covariate constrained randomization where there were over 100,000 random allocation schemes from a possible 1.68 times 10 to the power to 24 possible schemes. We then selected those schemes with good balance on a set of baseline characteristics, and then we randomly selected one randomization scheme from those with good balance. And that resulted in us having good baseline balance on the characteristics between the 2 groups in the trial. In terms of implementation and impact of the intervention, the trial and the trial intervention was embedded in routine care. Before launching the trial, we did a study to understand the barriers to implementation, which is published. And this guided our use of education, new medical directives, and ongoing feedback to support over 2,000 nurses to deliver personalized cooler dialysate in the trial without research coordinators at the participating centers. So let me take you through how we did this. What we were trying to achieve is how do you get health professionals to implement a protocol, either a research protocol or even a clinical protocol in busy healthcare environments. And I think we all appreciate the barriers to clinical behavior change are complex and involve multiple factors at multiple levels. So prior to the trial launch, we worked with Dr. Justin Prousseau, a health psychologist at Ottawa, And we interviewed 9 dialysis nurses and 9 physicians, where we systematically documented what they shared were the perceived barriers and facilitators to adopt the intervention. And we considered these barriers in a framework of behavior change. So, for example, one of the concerns might be belief about consequences. For example, the barrier may be the nurse may feel my workload will increase if I adopt and have to implement personalized cooler temperature dialysate. And so you can offset this by sharing in the information materials that evidence suggests there's less intradialytic hypotension. And if people are not dropping their blood pressures on dialysis, that could reduce your workload and stress. Another area might be the environmental context and resources. For example, some dialysis machines only change the temperature in 0.5 degree Celsius increments, not 0.1. And so our procedures had to account for that. Maybe there are not enough thermometers in the dialysis unit, so you have to fix that before the trial starts. We allowed any type of thermometer, whether it was oral or tympanic, to make the trial very pragmatic. Also, you have to account for things like what if the patient is drinking liquids or chewing ice, or they come from a very cold environment, and how's that going to affect the temperature reading? So you have to think about how this will be done in routine care and how to minimize the chance of error. Another area would be the social professional role. For example, nurses might say, we need a global order or policy change or medical directive so we can set the personalized dialysate temperature in routine care. And that's something we did in some sites. Also, we want to regulate behaviors. For example, nurses might say, if a patient feels cold, I increase the dialysate temperature, but we can provide other opportunities to help patients in this regard. For example, you can use blankets to warm the extremities without affecting the core internal temperature. Also, you can share knowledge as part of the materials, like lowering the dialysate temperature. They might feel is only useful if patients are experiencing interdialytic hypotension, but we can show that the data doesn't show that. In fact, most people in the previous trials were routine dialysis patients. And so using this information, you can optimize the intervention and its delivery in busy healthcare environments before the trial. And this guided our orientation, in-services, communication, print materials, FAQs, medical directives, and monitoring and feedback during the trial. In terms of the statistics, this was carefully thought out, and we had a detailed published statistical analysis plan. By design, we needed to account for the correlation of outcomes in dialysis centers, which were the clusters, and the variables used in the constrained randomization. And so for the primary outcome, we assessed the subdistribution hazard ratio using a multivariable generalized estimating equation to account for the clustering of patient outcomes within centers and the competing risks of non-cardiovascular death. And the model accounted for the randomization approach by adjusting for covariates constrained in the randomization. In terms of ethics, consent, and regulations, cluster randomized controlled trials raise complex ethical issues. We recognize many patients who receive dialysis as a life-sustaining therapy are very vulnerable, and we need due care to make sure our research approaches maintain trust in the population. Patients, healthcare providers, researchers, and renal agencies are all aligned in a commitment to making dialysis better and figuring out new ways to generate high-quality evidence efficiently, making dialysis centers hubs of innovation rather than despair. With this particular intervention, there was no commercial interest. In this trial, the Research Ethics Board approved opt-out patient consent, where patients were notified about the trial during the trial. Specifically, the dialysis director and healthcare providers needed to provide consent for MyTEMP participation at the 84 centers. And in truth, there were hundreds of stakeholders in Ontario who approved this trial and felt it was a sensible thing to do, including patients, healthcare providers, and the renal agency. Patients were notified about MyTEMP through posters and pamphlets. And through MyTEMP, we learned about how to do this even better in future trials. A patient or their nephrologist could decide to opt out of the randomly allocated center-wide default policy, and they could also opt out of the de-identified survey that collected symptoms in the 10 centers. But they could not opt out of de-identified health records, which are collected as a part of routine care even outside this trial. There is no documentation of consent to trial participation. When one considers the Tri-Council Policy Statement for the Ethical Conduct of Research Involving Humans, or TCPS2, Articles 3.1 to 3.5 refer to the consent process, which is patient choice. That it should be voluntary, that participants are not at a disadvantage if they withdraw from deciding to participate in the research, that it's informed and it's an ongoing process. In the case of this trial, we're trying to be responsible in balancing what is feasible and also what is comprehensive. There are other articles in the statement, and all articles 3.12 describe how consent can be documented or should be documented in trials. The Tri-Council Policy Statement also has Article 3.7a, where the REB may approve research that involves an alteration to the consent process. The REB approved our request for MyTEMP to use such a process. In doing so, they considered several criteria. That the research or that the trial introduced no more than minimal risk beyond usual care. That it was the same as switching to an alternate dialysis center for patients in the trial, which is similar to a quality control measure implemented by hemodialysis directors. To be clear, it doesn't mean that the intervention is a minimal risk, because all interventions have some risk. We were trying to determine if the intervention had an impact on cardiovascular events and non-cardiovascular mortality. And some risks are unknown until a trial is completed. Again, this is saying that participation in the research didn't result in any additional risk to patients. Other criteria are listed here, including that alternate consent requirements are unlikely to adversely affect patient welfare. It's otherwise impossible or impractical to carry out the research to answer the question. The precise nature and extent of the proposed alteration is defined, and there's a plan to debrief patients after the trial. With respect to the trial materials, we created, as mentioned, implementation materials as well as materials after the trial to debrief everyone about the results. This trial was only done through substantial support and partnerships, including the support of our provincial renal agency and the 27 regional renal programs that managed all these dialysis centers. Also, we consulted patient and family advocacy groups, and our patient partnerships are described in a separate publication for this trial. The trial was developed and authored with patient partners. The trial was presented to kidney patient and family advisory councils, which guided our choice of additional outcomes, resulted in updates to the trial letter. The symptom sub-study was developed with patient partners. A patient partner featured in the introductory video explaining the study. Through this trial, we continue to build our knowledge and experience on Indigenous rights and data sovereignty. We recognize Indigenous peoples in Canada are disproportionately affected by kidney disease. And through our work, we want to contribute to a history of randomized trials done in a safe, respectful, and culturally appropriate way. Through this trial, we've gained great awareness around considerations around dialysis centers that are close to reserves and perhaps even on a reserve, how we should design the notification and patient-facing materials to have different languages, including potentially Indigenous spoken languages. In terms of this particular trial on quality control and oversight, we monitored adherence to the intervention, and we promoted activities that improved the adherence. We really wanted separation between the two groups. And this is perhaps a less pragmatic feature of this trial. With respect to the data, almost all the information came from large administrative healthcare databases that also includes our Ontario Renal Registry. These data were accessed through the Institute of Clinical Evaluative Sciences. As most people are aware, the coders who provide the data into these data sets would be unaware of the trial in this open label trial. We were able to analyze the historic data pre-trial to guide the protocol. We helped us understand patient movement between dialysis centers, becoming transplanted or switching to home dialysis, or event rates and competing risks. We use validated codes to assess the outcomes, and we also use the data sets to perform the covariate constrained randomization. Also, we use the data sets to understand the importance of our primary outcome and published on this. Besides being clinically important, we showed that the cardiovascular-related hospital admissions, as assessed by codes in Ontario, amongst patients receiving hemodialysis, use significant healthcare resources. For example, the median duration of a hospital stay for myocardial infarction in Ontario is 5 days, and for ischemic stroke, it's 9 days. In terms of inclusion, diversity, equity, and accessibility, it's been shown that participants in trials, and even in hemodialysis trials, differ from those who receive hemodialysis in usual care. And this is not unique to dialysis. This occurs in multiple areas of medicine. In this trial, we provided estimated treatment effects in a large representative sample of patients, approximately 96% of patients receiving maintenance hemodialysis in Ontario, including those with multiple comorbidities who were often excluded from clinical trials. In terms of the financing and resources, this trial cost approximately $2.5 million Canadian. We certainly learned a lot, and if we did it again, I think we could run it more efficiently. In contrast, if we did this in the traditional way, I would expect this trial to cost upwards of $8 to $10 million, if not more. Also, our approach has meant that we conducted the trial on time. It wasn't disrupted by COVID compared to what would occur with a traditional trial. So on that note, I hope you enjoyed hearing about some of the nuts and bolts around this trial, and thank you for listening.